Ladies and gentlemen, good morning, and our apologies for this delay in starting this webinar. Technical error was the cause, and again, my apologies. Today is the 23rd of August, and our topic for the Diabeat webinar is diabetes, a metabolic syndrome. Now, what exactly is a metabolic syndrome? It usually involves 4 factors: abdominal girth, you could say above 40 inches in male and 35 inches in female, high blood pressure above 130/85, triglycerides at about 150 and above, fasting blood sugar at 100 and above. And amazingly, this combination, which is referred to as the metabolic syndrome, results in devastating impacts: cardiac ailments, cancers. 60% of the human population is cardiac prone, and 30% would have some correlation with cancer, and 18% would have diabetes. Now, what causes these things? The metabolic syndrome is a combination of medical factors, triglycerides and blood sugar and hypertension with the abdominal girth. It results in medical ailments, but surprisingly, the causative factors are within our control. You are talking about avoiding a high-fat diet, avoiding living a sedentary lifestyle and having some physical activity, avoid stress, have sufficient sleep, avoid smoking, alcohol, manage your weight and BMI. And if you do these things, your probability of a metabolic syndrome may perhaps be less. But then I must tell you that this is a layman speaking. To talk on this exciting topic is a renowned specialist, Dr. Hala, and we owe much of the diabetes challenge to her esteemed advice. Dr. Hala is the head of Department Endocrinology in the RAK hospitals. She has a master's degree, which she completed in '87 and got her MRCP in 1999 and an SCE in endocrinology and diabetes in 2011. She has over 3 decades of experience, not just in the UAE, but also in other locations such as Kuwait and Egypt. Her work comprehensively manages diabetes and other endocrinic disorders. And those endocrinic disorders include thyroid disorders, pituitary disorders, adrenal disorders, metabolic bone disease, polycystic ovarian syndrome, the management and also the management of diabetes-related comorbidities, such as hypertension and dyslipidemia and obesity. Ladies and gentlemen, I present to you an extremely experienced and knowledgeable individual who is going to talk to us about metabolic syndrome, about the combination of these ailments that have a devastating effect. Ladies and gentlemen, Dr. Hala.
Thank you, Professor Kennedy, for your introduction. And I hope the talk today will be helpful to our colleagues. You can see the slides now.
Not as yet, Dr. Hala.
Now you can see them?
Yes.
Okay. So diabetes and metabolic syndrome. Diabetes, as we know, is an important health problem, which has reached alarming levels now. Nowadays, almost 500 million people are living with diabetes worldwide. Metabolic syndrome has been associated with type 2 diabetes since it is both related to the increase in the obesity and a sedentary lifestyle. Individuals with metabolic syndrome are 5 times likely to develop type 2 diabetes. So, first, what is metabolic syndrome? Metabolic syndrome is the name of a group of risk factors that raises your risk factor for heart diseases and other health problems as a stroke and diabetes. Metabolic syndrome is defined as a cluster of cardiovascular risk factors, which include raised fasting plasma glucose, the central obesity, hypertension, raised triglycerides, and reduced the good cholesterol, which is called the high-density lipoprotein cholesterol. So obesity is the most common risk factor for metabolic syndrome, which, if not checked on time, puts you at the risk of type 2 diabetes, heart disease, heart attacks, or stroke. And these are the criteria, as we said: low levels of good cholesterol, high levels of triglycerides, high blood pressure, elevate and excess weight on the abdomen. So to diagnose and metabolic syndrome, there are 3 or more of the following. The central obesity with the waist circumference in men more than 40 inches and in ladies more than 35 inches. In Asians, there is less, 35-inch, and in ladies, 31.5 inches. The triglycerides, which is more than or equal to 150 milligram per deciliter, and the good cholesterol is reduced in men to less than 40 and in women less than 50 milligram deciliter. Blood pressure is more than 130/85, and the fasting sugar is more than 100 milligram per deciliter, or if the patient is diabetic already and on treatment. So 3 of these, then the patient will have a metabolic syndrome. Metabolic syndrome is caused by insulin resistance or insulin resistance linked obesity, which is also known as syndrome X, and it has been recognized since the 1980s. So what is insulin resistance? Insulin resistance is a condition in which the body can't use the insulin properly. He had the insulin, but he cannot use it. And insulin, as we know, is a hormone secreted by the beta cells of the pancreas. It helps to move the blood sugar into the cells where it is used for energy. So insulin resistance can lead to high blood sugar level because it will not pass into the cells. And it's closely linked to overweight and obesity. So metabolic syndrome is thought to be caused by the adipose tissue dysfunction and the insulin resistance. Both adipose cell enlargement and infiltration of the macrophages into the adipose tissue will result in the release of the pro-inflammatory cytokines and promote the insulin resistance. Insulin resistance appears to be the primary mediator of the metabolic syndrome. Insulin helps the glucose uptake in the muscle, in the fat, and the liver cells, and can influence the lipolysis and production of glucose by the hepatocytes. So fat that is visceral or intra-abdominal, and this is the bad fat, it is visceral or intra-abdominal. It correlates with the inflammation, whereas subcutaneous fat does not. So abdominal fat is known to produce potentially harmful levels of cytokines as tumor necrosis factor, adiponectin, leptin, resistin, and plasminogen activator factor inhibitor. So now we see that this visceral fat acts as an endocrine gland and secretes many things which promote this obesity. We have to understand also that it is not only the fat caused by the lifestyle, but also there are genetic regions which are known now to influence the obesity traits. The first gene, as we know, long time related to obesity was the FOT gene. So these genes also, because of that, many patients ask, we are doing some style life modification and still we are not losing the weight properly. Yes, there are genetic traits which sometimes does not help us to lose weight quickly. So there is 70% heritable genes expressed in the brain, and the person which affect the personal appetite system, regulate the weight, the appetite, the metabolism, and sometimes evolve for calorie scarce environment. When they are very restricting, they are evolved more, progressively defends against the fat loss. In the other hand, diabetes mellitus is a metabolic disease defined by hyperglycemia. For type 2 diabetes to occur, there be both insulin resistance and inadequate insulin secretion must exist. So for example, all overweight individuals have insulin resistance, but diabetes develops only in those who cannot increase the insulin secretion sufficiently to compensate for their insulin resistance. So increased blood glucose, of course, will be caused by increased carbohydrate intake. On the meantime, decrease the peripheral glucose uptake, and this is what we call the insulin resistance. With decrease the insulin secretion and increase the hepatic glucose production. All will they contribute for the development of the increased blood glucose and type 2 diabetes. To diagnose diabetes, we do the glucose tolerance curve, in which the patient is giving 75-gram glucose, and after 2 hours, we check his sugar. If it is more than 200 milligrams, then this patient is diabetic. If it is between 140 to 200, then this is a pre-diabetic and he has a impaired glucose tolerance. And in the fasting, it will be normal if it is less than 100. If it is more than 1 to 6 milligram, then he is diabetic. And between 100 milligram to 1 to 6 milligram, he is the pre-diabetic or has the impaired fasting glucose. The other tool which we diagnose diabetes is the HbA1c, the glycated hemoglobin. Glucose in the blood sticks to the hemoglobin to form the glycated hemoglobin. And the high glucose levels in blood, more of your hemoglobin will be coated with the glucose. And as the RBC's lifespan is 120 days, so the HbA1c measures the average glucose level for the past 3 months. So if it is more than 6.5, then the patient is diabetic. If it is less than 5.7%, then he is normal. In between, this is the pre-diabetic stage. Diabetes mellitus is associated with a 3 to 5-fold increased risk for the development of metabolic syndrome, which has now reached high proportions in many countries. So now, metabolic syndrome can lead to diabetes mellitus, and vice versa. Diabetes mellitus also will lead to the metabolic syndrome. So older age, female gender, high BMI, obesity, higher blood pressure, low good cholesterol, which is the high density lipoprotein level, and the waist circumference significantly contributed to an increased risk of metabolic syndrome among diabetic population. Metabolic syndrome, or syndrome X, or insulin resistance, is a serious health condition that puts people the higher risk of other health problems. Numerous associated cardiovascular complications, particularly coronary heart disease, heart failure, aortic stenosis, ischemic strokes, and possibly venothromboembolic disease. Cardiovascular disease and diabetes mellitus coexist and are two leading causes of death. Emerging data suggests an important correlation between metabolic syndrome and the risk of a stroke. Metabolic syndrome may also be linked to neuropathy beyond hyperglycemic mechanisms through inflammatory mediators. The abdominal adiposity is associated with the increased risk of cardiovascular events. As the waist circumference is increasing, then we see that the relative risk of cardiovascular death, of myocardial infarction, and even all-cause deaths are increased. And as we know, diabetes can cause blindness from the retinopathy and retinal detachment, increased premature cataract, kidney failure, heart attacks, strokes, and lower limb amputation from the neuropathy and the ischemia of the limbs. So, the main goals of treating metabolic syndrome are to lower your risk of heart disease and to prevent type 2 diabetes if it has not already developed. Lifestyle changes are the key to managing the conditions that contribute to metabolic syndrome. And even if we have the genetic traits, lifestyle changes are helping to manage these. These changes include maintaining or working toward a weight that is healthy. Losing 7% of excess weight can reduce the onset of type 2 diabetes by 58%. Lifestyle changes and weight loss are considered the most important initial steps in treating the metabolic syndrome. Healthy habits as quit smoking or never smoke, maintaining your weight to less than 25 kilograms per meter square, physical activity of at least 150 minutes every week, 4 to 5 key components of a healthy diet as vegetables, roots, less fats, no frying, total cholesterol of less than 200 milligrams, blood pressure below 120 over 80, fasting sugar less than 100. Evidence exists to support that the diet, exercise, and pharmacological interventions may inhibit the progression of metabolic syndrome to diabetes mellitus. The exercises is very easy. We need not to go to the gym and paying much money. Only bicycling, walking, stairway walking, or wear water aerobics, swimming. Any exercise will help us. Getting regular exercise. Why? Because physical activity helps to combat the insulin resistance by increasing your insulin sensitivity. Eating healthy foods, getting quality sleep is very important. Avoiding or quitting smoking, managing stress, either by yoga or meditation, is very important. As high levels of cortisol over long periods of time can increase the triglycerides, blood sugar, and blood pressure. So stress is very important. in increasing your weight and increasing your risk of developing obesity. Our therapeutic goals for management of the metabolic syndrome: for the primary target, elevated LDL, which is the bad cholesterol, to be less than 100 in high risk, and moderate risk less than 130 and less than 160 for low risk. We have to target the high density lipoprotein to raise to extent possible with weight reduction and exercise. Elevated blood pressure to reduce it to less than 130/80 if you are diabetic. Elevated sugar. For type 2 diabetes, our target is the A1C less than 7%, and in very tight controlled to be less than 6.5. The prothrombotic state with low dose aspirin for high risk patients, and the pro-inflammatory state lifestyle therapies is advised. Medication and treatments for managing metabolic syndrome. We have medicines to lower blood pressure. There are many groups: the ACE inhibitors, angiotensin receptor blockers, diuretics, beta blockers, calcium antagonists, and medicine to control the blood triglycerides and the good HDL cholesterol levels, as statins, niacin can help lower the triglycerides and bad LDL cholesterol. So in all dyslipidemia, diet and exercise is mandatory. To lower, if our target is not reached for the low density lipoprotein, then we have to add the statins. For the triglycerides, we have to add fibrates and niacin. If the target not reached, then combined treatment with ezetimibe and the statins can be used. Medicine to lower blood sugar levels in metabolic syndrome is the insulin sensitizers, as metformin and thiazolidinones can help. And weight loss medicines, they can help you to lose the weight by making you feel less hungry. Data are available for the liraglutide, which is the Saxenda, the semaglutide, Wegovy, and recently the tirzepatide, which is the now very common, which is the Mounjaro, regarding the management of people with obesity. With this data, obesity management is enriched with medication. The last resort is the weight loss surgery. Bariatric surgical procedures affect the weight loss through three mechanisms: malabsorption, restriction, and neurohormonal response. The ghrelin, which is a peptide hormone, which let us feel hungry. It is secreted in the foregut, in the stomach and the duodenum, and it stimulates the early phase of the meal consumption. The normal pulsatile release of this oxygenic appears to be inhibited in the gastric bypass patients and the laparoscopic sleeve gastrectomy. Hormones such as the GLP-1 are increased and may promote an anorectic state where we feel always not hungry. So our recommendation for this topic is to screen all adults for obesity. Offer or refer patients with a body mass index of 30 kilogram or greater to intensive multi-component behavior interventions. It applies to all adults, not just those with known cardiovascular risk factors. Screen children 6 years and older for obesity and offer or refer them to comprehensive intensive behavior intervention to promote improvement in weight states. As we see now, obesity in children are increasing too much. 5 to 10% weight loss can reduce the risk of heart disease, diabetes, and should be encouraged for all patients who are overweight and obese. We have considered pharmacotherapy if the style medication and the style life modification is not working with the patient. We give him trial if this, and he is doing his best, but still he will not lose much weight, at least 5% after 3 months. Then at that time, we can start the pharmacotherapy to BMI of 30 kilogram or greater or BMI of 27 kilogram per meter square or greater, and the obese-related comorbidity. We have to consider bariatric surgery in adults who have not been able to lose weight through diet, physical activity alone, and who have BMI of more than 40 or greater, or BMI of 35 or greater, and obesity-related comorbidity. Regardless of the body weight or weight loss, all patients should be encouraged to be physically active for improved health and weight maintenance. Regular physical activity is strongly related to maintaining normal weight. Exercise also mitigates health damaging effect of obesity, even without weight loss. Still, we encourage the patient to exercise. Thank you very much.
And thank you, Dr. Hala. Thank you so much. Thank you so much. Now, I must tell you, in order to understand a little more about what you might be saying today, I went back and I looked at a presentation that you had made 2 or 3 years back in a different forum. I looked at it and it gave me tremendous comfort to know that metabolic syndrome could be handled. However, in today's webinar, I had a moment of fright when you pointed out that there were 140 genes related to the metabolic syndrome. And I thought to myself, well, it would seem that we do not have this under control, is what I thought. And then, of course, you came up with 2 remedies. One remedy was lifestyle change, about which you spoke so eloquently. In a simple way, you said, if you simply lose weight, you can reduce 50% of your risk. And that is a profound statement to make. And I'm grateful for that. And then you so eloquently and scientifically went into pharmacotherapy or pharmacotherapeutics, which of course is the final answer. You touched upon bariatric surgery also. So it is not you who has to say thank you to us, Dr. Hala. It is we, your listeners, who have to say thank you to you. But we can't let you go at this minute so easily. I am sure that my friend and colleague, Dr. Wilku, will have so many questions, and our several participants will have so many questions. But I must congratulate you, Dr. Hala. Your presentation of 2 years back was completely different from your presentation today. It indicates to me a vast growth in knowledge on your subject. Thank you so much. And which also reminds me, friends, those of you who are listening, this website gives you all the webinars of the past, and it contains abundant knowledge. Use it to great advantage. But I have said too much already. Sir, Dr. Wilku, sir, the floor is yours.
Thank you, Professor. Thank you, Dr. Hala, for a wonderful presentation. Really, like Professor said, completely new content for thing. We also learned so many points which we overlook many of the times. So thank you very much for that. There are a few questions which but unfortunately I'm receiving many questions in my WhatsApp instead of the chat box. Maybe people are not attending there, but I will take first question from Har Sahaj. Yeah. My sister on routine annual check had high cholesterol, for which she's taking Lipitor. Her fasting sugar came very high and random sugar was normal with HbA1c 5.4, which is normal. since last 4 months, she's taking, she checks fasting and PP sugar every month. Fasting sugar comes high, whereas PP and random is very normal. We don't have a family history of any diabetes or any metabolic syndrome. She doesn't have any other problem. Is she suffering from diabetes? Quite good question.
Yeah. So what is the fasting sugar? How much it comes?
He has not mentioned. I will check.
Because sometimes if it is written in the lab, if it is 109, this is considered high in the lab because usually it is less than 100. But it is 109, so maybe she is a pre-diabetic. So the fasting, how much? High, how much?
Yeah. He just WhatsApped.
Yeah,
One
because the
second.
HbA1c is 5.4. So maybe the
136.
fasting is,
He's saying around fasting between 136 to 148. Every time, whenever she checks, see it comes between this
okay, and
136 to 148.
she did the glucose tolerance test?
She's on. She's only
Because
on Lipitor.
no, I mean when she's on diagnosis, she did the glucose tolerance test
No. I think so. No.
so that we can see
Maybe I
how much
don't.
it raises after a glucose load. And sometimes, if it is only the fasting and she is young lady, sometimes this is the monogenic diabetes. There is a type which is called glucose 6 phosphate deficiency, in which only the fasting raises slightly. It comes more in pregnancy, and usually it doesn't need medicine. It doesn't need treatment, only the diet. But it depends what is the condition is.
Yeah, because he has mentioned her HbA1c is 5.5, 5.4, which is normal.
Yeah.
Okay.
So
The
in pregnancy,
second
it will raise more
question.
if she will needs medicine, but without pregnancy, maybe she will not need anything. So she has to be diagnosed whether this is type 2 or monogenic diabetes.
Yeah, true, because he has not given the complete history of that. Mr. Piyush has asked, what is your takeaway message for all diabetic care? I think Dr. Hala has gone out. Unfortunately, she is out. There was a technical issue with there. Professor, shall we wait for this or we can take the questions? Let me check with her first.
Dr. Wilku, if there are questions of a general nature relating to the diabetes challenge, you could take those questions till such time as Dr. Hala joins. In case Dr. Hala is unable to join, then we've been fortunate enough to hear her presentation. We could wrap up soon after you answer the questions of a general nature that relate to the challenge.
Okay, give me 1 second, sir. I will just check whether she is able to join again or not. Her system gone down. Okay, no problem.
Is she unable to join?
Yeah, actually her system went down. Okay, we'll take other questions. The second question was, The takeaway message, Mr. Piyush has asked, takeaway message for all for diabetic care. Like Dr. Hala mentioned about, you must be, if you have family history, if you have any other metabolic syndrome, you should be regularly doing the checkups so that you know where you stand. And second, things you should be having a proper and balanced diet and doing an exercise. These are the three basic pillars you should be following up for general care. And if there is any complicated medical history or medical complication along with that, then you should be consulting your physician. Okay. One question is being asked from SF. What is the best diet to reverse pre-diabetes? Definitely. See, the pre-diabetes is a condition where you are about to become diabetic, but yet there are chances you can handle it with the lifestyle modification. And diet is one of the biggest player for diabetic management and reversal. If you are pre-diabetic, definitely you can reverse it. So first, two, three things here I'll be mentioning about it. Definitely, our next webinar will be on completely nutrition. That will be very good to attend. And but broad line, I will tell you, whenever you are eating, your portions for carbohydrate should be less. Your protein and fiber should be more. That is one part. Second, whatever you eat, look for the glycemic index. That means the sweet index. That is the thing which spikes the blood sugar and the feedback mechanism for sugar metabolism. So that is one. Avoid juices. Whatever you eat, eat whole fruit, whole grains, whole vegetables instead of deep frying, making it juice, making it smoothie. That will help you very much. And then go for probiotics also. This will be the broad line thing. Okay, John Boras has asked if sugar raised to 250 after eating. After eating, do I need to change any medicine? No, Mr. John. That you should see only checking the sugar. If it means you are checking at home, so for a regular monitoring, that's good. You should monitor it. But if it is coming every time and your medication is what medication you are on, you should consult your physician for a thorough investigation why it is happening and whether anything related to is associated or not. So that should be the thing. Okay. Suzanne has asked, I started doing exercise as Dr. Hala instructed. Very good. You should be doing it, and you will definitely, if you sustain that effort, if you continuously do exercise and monitor your diet, and you will be getting a good result. 1 second. Yeah. Then question, because I'm getting many questions from WhatsApp also. Yeah, Rathore has asked, I read long-term blood pressure and cholesterol medicine can lead to diabetes. Is it true? Okay. Dr. Hala is not able to join. So this question, see, definitely there are some links for certain medication and depending on the individual's response to the medication and metabolic syndrome. So better you should be consulting your physician. The best consultant should be the endocrinologist or an internal medicine to have other tests. Then next question is, short form is given. My glucose last month is 280 and HbA1c was 12.1 after the start of this challenge. This month I'm now 120 glucose and 9.41 HbA1c. Is this good progress after following some exercise and diet? Definitely, this is a good progress. But the HbA1c fall from 12.1 to 9.41, you should be concerned of. And if you have increased the dose, whatever on medication you are, if you are, so be careful until unless you consult your doctor. Don't do yourself. Just keeping in mind, only for the challenge, winning a prize is nothing good. You should be having a good health because dropping within a month from 12.1 to 9.41 is little suspicious. Take care of yourself. Consult your physician, whoever is treating, and whatever the medication you are taking, don't overdose yourself. Dr. Ali has asked, explain monogenic diabetics single gene. Definitely, this will be the best answered by endocrinologist. So we'll put this to Dr. Hala by email, and you will get the response through email. I will not go into deep into that. I don't think so. Any other question is there? 1 second, Dr. Hala has mentioned. Professor, I think there is no more question. Whatever questions I'm getting, all are related to it. So over to you.
Thank you. Thank you. Thank you, Dr. Wilku. I hope I am not on mute.
No, sir.
I'm not on mute. Good, good. Dr. Wilku, thank you so much for answering those questions on behalf of Dr. Hala. Thank you so much. Just some general thoughts about one or two of those questions. The takeaway message. Very clearly, Dr. Hala spoke about therapeutics, pharmacotherapeutics, which means medication, but she also strongly emphasized lifestyle change, simple things like exercising every day, managing your diet, sleeping well, avoiding too much of alcohol, and things like that. And that is a major emphasis of this, of the diabetes challenge. And again, I must congratulate the gentleman who started with a 280 fasting blood sugar level and dropped to 120, and at the same time, HbA1c from 12.1 to 9.4. Dr. Wilku, as all good doctors, you have gone into the depth of this situation and said, well, I hope it is not only therapeutics, because it's a big drop. True. He's in the right direction, of course. But if it was not simply therapeutics and it also was lifestyle, I have to say thank you. But I noticed that Dr. Hala is back on the on our webinar. So perhaps, Dr. Wilku, you may want to present these questions to Dr. Hala. One about the monogenic genes, and again this one. Dr. Hala, may I ask you a question, ma'am?
Yes, sir.
You know, we have a gentleman over here who mentions that his blood glucose levels fasting at the time of starting this program was 280, and when he took it 1 month later after doing lifestyle change and other such things, it dropped to 120 fasting, and his HbA1c from 12.1 seemed to drop to 9.4. Now, the question over here is, in your wisdom, Dr. Hala, is this due to medication or is this due to lifestyle?
Lifestyle is difficult to let it like this, very difficult, unless he's starving. And if he is starving and doesn't eat any carbs, how long he will be continuing on this? The problem that even if he can continue 1, 2, 3 months, but this is not our aim. Our aim is for life. So to be reasonable, he should take some carbs, but to let it like this so rapid down, mostly he doesn't take any carbs. And this is for long term will not be good for his health. This is my opinion.
Thank you, Dr. Hala. Your wisdom, thank you so much. I'm quite sure the gentleman who asked this question was listening in. Dr. Wilku, your question, sir.
Yes, Professor. Ma'am, that was good. Now, Dr. Ali has asked, please explain monogenic. You have mentioned about monogenic for one of the questions. And please explain what is monogenic diabetes.
Okay, monogenic diabetes, this is a sort of diabetes in which there are some genes affecting the action of the beta cells. So it is hereditary, autosomal, dominant, and there are 6 types. Okay, at that time, they are usually young age. They are not fulfilling the criteria of type 2, in which the lipids are not too high. There is a strong family history coming early in the 20s of their ages. And at this, we should see whether this is type 1 or type 2 or the monogenic. The monogenic is properly diagnosed if the patient has no insulin antibodies, the peptide is still secreting, and in the same time, there is a genetic test to see the genes which is affected. And mostly they were improving by sulfonylureas because this class will stimulate the pancreas to secrete the insulin. Usually we don't like the sulfonylurea except in this monogenic diabetes.
Yeah, true. Doc, there is one interesting question. First time for 3 years of challenge, we have got this question. SF has asked, does having iron deficiency anemia increase weight gain and cause metabolic syndrome problems? Iron deficiency anemia.
The patient has iron deficiency with the metabolic syndrome. I cannot understand the question, please.
No, he is asking, does iron deficiency anemia increase weight gain or can cause metabolic syndrome? Is there any relation between iron deficiency anemia and weight gain and metabolic syndrome?
No, unless this is an organic cause of the weight gain. If he has an hypothyroid, yes, hypothyroid can cause iron deficiency anemia. But if it is only metabolic syndrome without any cause of this obesity, there is no correlation unless he is not taking proper food or there may be some malabsorption. We have to investigate why there is iron deficiency anemia, either from his intake or the malabsorption itself, or there is blood loss, so that we can see why there is iron deficiency. The obesity itself, no, it will not cause iron deficiency anemia.
Yeah, yeah. There is one question which you can be able to answer properly. There is one direct question, but I am putting it to you. Is the monogenic test available at RAK Hospital and covered under insurance?
No.
No, because the genetic tests are very unlikely to be covered. Okay, and okay. John has asked, he has asked about another question is there. After eating, my sugar rise to 250 and take 3 to 4 hours to go below 180. Do I need to change my medication?
Either changes his medication or change his diet. Maybe he's taking too much carbs.
Yeah.
Maybe he's,
Yeah.
so either. So it depends what does he eat. He has to modify his diet, and then if it is still, then he can modify his. There are some medicines which helps to decrease the postprandial blood sugar, and other medicines which helps to decrease the fasting sugar. But depends on what he is taking and how the mode of eating of his diet.
Yeah, true. And it also depends whether he's taking the medication properly or not. Many people skip medication frequently.
Yeah.
So he has to be very religiously. I think I'm over with the questions. Professor, over to you.
Dr. Hala, I am so impressed. I am so impressed. I had a moment of happiness in a manner of speaking, light-hearted happiness in a manner of speaking, when you answered the last question and the gentleman asked, my blood sugar level after 3 hours is dropping from 250 to 180. Should I change my medication? And you simply, as is your personality, said you could change your diet and reduce your carbohydrates. I thought that was a straightforward, simple answer. But of course, you also went on to mention the pharmacological benefits of different types of medication. But the simple, profound statement of just reduce the carbohydrate would then mean that at the starting point itself, it would not be 250. So I thought that was a profoundly wise answer. So thank you once more, Dr. Hala. Thank you once more. You are full of simplicity, but you are so full of wisdom. Thank you so much for that. Thank you so much. Dr. Wilku, thank you, sir. Thank you so much. You had the onerous responsibility of standing in for Dr. Hala for the 5 minutes in which she was offline due to some technical glitch. And I have to tell you that I'm grateful that you were able to fill in that time. Thank you so much. Thank you so much.
Thank you.
My IT colleagues, I know you had a difficult time with your IT-related problems, but then you brought us back on track, and Dr. Hala is at the finish. Thank you so much for that. And the AWLM team, which is the team in the background that is putting all of this together, sitting in the next room and sorting things out. AWLM, thank you so much. And of course, not to forget our big brother in the hospital next door, RAK Hospitals. Thank you for your support. And good day. We look forward to seeing you again next week. Goodbye.